Good afternoon, everyone. Today is November 12th. One other thing I'm going to actually mute Dr. Liquido because you'll be able to hear otherwise. All right, so, okay, she did mute. I'm sorry, I'm going to just restart. So, Sean, you're on mute as well, but you don't need to be on mute. Good afternoon again. Today is November 12th. This is United Medical ACO and our weekly update for Delaware Health and Community. And today we are gonna discuss several different topics. And basically what we have, let me just share my screen first. Once we have the COVID updates, we'll be able to have some healthcare updates from the value-based contracts, but also we are going to bring Dr. Jennifer Nichiro from United Medical Clinic. We are going to discuss the pediatric vaccination for COVID-19. So what I would like to do is just to start with the vaccine updates, the global level and the US level, and then we'll go into the Delaware, and then we'll bring Dr. Liquido right after that. So right now this is just on the global level where we are right now is, it's about 72,000 new infections reported in the United States. This is the next closest one is Russia with 39,000, and United Kingdom 34, Germany is 31, and Turkey, surprisingly, they are still at 27,000. They're in the top 5. So these numbers are high. When you look at total number of people who lost their lives, Russia is with 1,211. It's 1,148 from United States, 681 from Ukraine, 400 people from India, and Romania is 347. These numbers are not necessarily correlate with the actual infections, but when you look at the total number of vaccinations, some of them does make sense pretty clearly. Again, from the global level, what we also have is, well, from United States standpoint, for us not to be on this top, how many do we have here? How many countries? So 1, 2, 3.
Maybe like 12 or so, it looks like.
8, 9, 10, 11, 12, 13, 14, 15. We are not in the top 15. Mm-hmm. So, and some of these countries are smaller, but just from the Western countries, it's only like a couple of them made to the list. And this list actually is, it's good for those countries, but for countries with bigger populations should be in the top 15 by now, and it's not happening. So we will be seeing the impact of those, I believe, in the near future. And that's kind of like something that we are worried about. Now, Sean, you're going to cover the Delaware and the US updates.
Yeah, so if you look at the last week, we had about 82.3% of the population in the state of Delaware having received at least one dose of their vaccine. It went up a little bit, about 0.7%. So now we're up to 83% total for the state of Delaware. And then if we do acknowledge down there, our total fully vaccinated population went from 532,000. So we gained about 2,000. Now we're up at 534. And then again, our breakthrough cases down there did increase slightly. But again, like you said, the efficacy is not 100% with anything. So it is to be expected that a few will continue to increase as well. And then again, here's just another chart looking at the total vaccinations of Delaware. So you see, we still have that uptick going towards the middle of November. Again, I mentioned last week, we know the holidays are coming up. A lot of people will be traveling long distance, interacting with families and friends at gatherings. So we anticipate that has an impact, as well as the availability now of the younger population able to get a vaccine. So the children are now eligible. So that may also be impacting the uptick.
All right. So this is at the US level, right?
Correct. Yep. So then this is just on our national level. So we have our total population of people fully vaccinated as 194.4 million. And then also just to mention, you do have to acknowledge that there's also the booster doses that are available. So people will start beginning to get those as we approach the holiday and winter season as well. And then that's just the same info on another graphic displaying the uptake again as we approach the middle of November.
So I think the important part on this one is because of the booster numbers are in it, it doesn't really actually show us who got the first dose and second dose. Right. And from yesterday's presentation, we had about 400,000 first dose in those 1.3 million daily numbers. So that is something that we have to be watching closely. Now, what I would like to do is I would like to ask Dr. Jennifer Nichiro to join us because she's in the middle of her office hours. And she would like to, we ask her to give us updates on the pediatric side. Dr. Liquido, are you able to come back?
Hello, good afternoon.
How are you doing?
I am doing well. It's Friday.
Thank you for agreeing to come on the session. And because I know that you guys are busy with the pediatric population, there were so many discussions for kids getting the COVID-19 vaccine. Now, actually, I just want to ask you to maybe just introduce yourself briefly, and then I have a couple of questions, and we'll just hear what you have to say with the entire process.
Okay, so I am Jennifer Nichiro. I am a pediatrician with United Medical Clinics and have been practicing in Smyrna, Delaware, for quite a while now. We leave the number of years to your imagination.
Thank you. So now the issue with the vaccine, COVID vaccine, was from the beginning, it was kind of problematic. So even for the people over 65 and then after 65 with the younger people and now with the pediatric. So now if you can actually give us, I have a couple of slides ready with the overall population, what CDC recommends, but just from the pediatrician standpoint, what your take is and what you have to tell us regarding the COVID-19 with pediatric.
Actually, yes. Thank you very much for the opportunity. Actually, if you hear what the pediatricians and what the American Academy Pediatrics have been, we've all been looking forward to getting kids vaccinated. So that is a general feeling among pediatricians. And maybe why, people would ask why, because definitely there is lower risk for kids, being severely sick from COVID, compared to adults and over 65 population. But we are excited because we want to get kids protected. Okay, definitely less risk, but there's still a significant number of illnesses. And I think I have some data in here that I pulled out earlier. So we're talking about, kids 5 to 11. And they said since the pandemic started, 1.9 million of 5 to 11 kids have been infected. About 8,300 of them have been hospitalized, and there have been 94 deaths caused by COVID. So this is quite significant. So we want them to get vaccinated. We want them to continue going to school and doing their sports, doing their activities. So we want to protect them as much as we can.
What's the total number of vaccination already given to kids? I think it was a couple of days ago, it was over 1 million.
It's around 1 million out of the 28 million of the population.
So now with this issue of people, their understanding of this is not being studied well and all that other stuff. When 1 million kids, they're being vaccinated, this is one of the biggest studies for kids, right? Like that could be done in that very short amount of time.
Yes, actually on the study that was presented by Pfizer, I think there were about 3,000 kids who were on the age range, so that they were able to determine, the dosing, the proper dosing, which would mount an immunogenicity or immunity that's similar to adults. So that's why they were able to determine that only giving like 1/3 of the adult dose will be equivalent to the protection that was being mounted by adults, with, of course, hopefully like lesser side effects.
So did you guys already start giving the?
No, we have scheduled for next week.
Next week. So United Medical Clinic will start next week. So in Delaware, in terms of the population who is going to get, who's eligible for vaccination. So I have this table here. So between 5 to 11, only like 2,400 people, 2,400 kids being vaccinated so far. This is as of 11/11.
From last week, right?
This is as of 11/11. So now I guess once we start the private offices or outpatient clinics, once we start doing this, it will be a lot more in the next couple of weeks. So what type of questions do you get from the moms and the parents?
Okay, those are very interesting. From the well-informed to the totally out there. Well, definitely the biggest thing will be, what the side effects are. So based on the studies, actually with kids, the common side effects, of course, will be like pain on the injection site, headache, fever, feeling tired. So those are the most common side effects that was on the study. So we give them that information, of course, and the other things will be, how the protection. Of course, based on the adult population or the over 12 population, we see that there's significant protection, but they can still get COVID, and there is waning protection. There's a possibility of giving boosters later on as well to kids, depending on what the studies would show. It may be different than adults because their immune system is a little bit different, but based on the trend, it may be similar, that we may boost like the flu, like every year that we may get a booster.
So are they going to be on the same schedule with like the first dose and second dose, or is it different for pediatrics?
It's the same schedule, 21 days apart. Yeah. The only difference will be 10 micrograms instead of 30 micrograms. So
why would someone not want to vaccinate their kids, like other than the side effects? I know we are in Delaware altogether, but we are in different counties, and you may have different feedback from the patients. Do you have any other than the side effects? Do you have some interesting reasons that they don't want to get vaccinated?
Yes. There are those who still believe that COVID is not real or it's not significant enough. One. Second, there are those who believe that it will alter something in their genes or with their reproductive health, which was like of note. This was also something that was like an internet rumor when Gardasil was first administered, or when Gardasil first came out, the HPV vaccine. So there were rumors that it will, make the kids not able to produce babies, so not be reproductive healthy. So I've had that question. Other far of things really is that they don't need it. They're okay. They're fine if they get infected, even though we say this is a global thing. Okay, it's not anything that's limited to our town or our state or our country. And we've seen kids like suffer. We've seen kids who have like long-term side effects. Not as much as adults, but it's there. So if the protection is there, why are we not going to take it? So
one of the difficulties I'm having, actually, it just happened today. So I was across the street at United Medical Clinic building. Second floor is Delaware Cardiovascular. and they are going through some transition with the system. So I was there to kind of see how everything was going. There was a patient, as we were exiting, there was a patient who's elderly, probably she was 70. She had a very nice mask, like one of those like shiny, nice, like designer-made masks. And I haven't been in the offices for a while, so I'm trying to kind of see some interaction with some people. And I just happened to ask her if she was vaccinated. I was just trying to have a conversation. And she said no. So I'm like, she's in a cardiology office. She has a mask. So then she's not vaccinated. So then I said, we have vaccine available downstairs. And then she said, no, I'm not going to get vaccinated. So then, of course, I didn't say anything, and then I left. Now, this is still happening, even for the population over 65. There's still some misperception, misunderstanding, misinformation. So it's going to be more challenging for the pediatrics because of two reasons that we have, right? So this whole idea of
we expect it to be a little challenging.
How can we overcome those, and how can we help you from the central office? I know that doing this is maybe helpful, but
that's right.
The answer sometimes I get like, well, I'm not a clinician, and then I have a clinician, so you are doing that role for us. Now, what else have you done from here, or are you personally doing something different to convince some of the parents who can actually get the vaccine for their kids?
Well, definitely bringing up the conversation every time. The good thing is we do have some parents who, when the vaccine was not yet available, they were asking us about, when is it possibly going to come? And if it comes, to call them right away. So we have that on the other extreme, the parents who are like more proactive about vaccinating their kids, who believe in the vaccine and who believe that they need to protect the kids from COVID. So we have those that are in the middle ground. And we've had actually some calls about, parents wanting to discuss the vaccination, trying to get information from us. Now, the other part that we are doing as well is, even if they're here for a well check or a sick visit, we'll tell them that we are going to start vaccinating. We get their information, get them on list, ask them questions. And I guess we just have to really be patient about talking to them about the vaccine, about the benefits and the side effects, and being very honest about what we know, and just entertain all the possible questions, and never tire about just proving what the science is telling us.
So this is an older article from CDC, but I think when I look at this cute kid here, if I'm in charge of her health, and if it's if I'm about to make that decision, and if something happens to that kid because of this problem, well, I don't know. Like, I think that's a big responsibility, and it's a huge responsibility, I feel like. So I just want to make sure that parents who are out there, they do listen to their pediatricians. Now, one of the things that I always tell our patients and our friends, that our physicians were the first one who got vaccinated.
Mm-hmm.
So, and in fact, that time I felt like, well, why are we not getting vaccinated? So, because in the business office, it took maybe about a month. But then there are still some hesitation. And I think maybe politically it was not handled properly, especially between the transitions that this just happened. So, and I know this is going to be a lot of work for you guys there. And we are here to support you if you guys need anything from us. And anything that you would like to share before you start going back, before you go back to your patients today?
Well, just a point, you brought it up that, when the vaccines came out, the physicians were the first to get vaccinated. Now, with this rollout too, my physician friends who have had kids at 5 to 11, I've already seen their posts about having their kids vaccinated. So that should probably, at least, if you believe your pediatrician, you believe your physicians, then that should tell you that if they are getting their kids vaccinated, then that means they believe that the kids are going to be safe, and they believe that the vaccines are going to protect their kids. So no amount of talk would probably overstate that. Okay, so they're having their kids vaccinated, then that means they believe that the vaccine will be effective.
And the other thing that I was going to ask you, I know this whole pandemic created a lot of pressure, not only on providers, but for our medical staff. So you work with our business office, like check-in, check-out, our medical assistants. How are they handling this situation during this, especially now they have to be asked with these questions by the parents. Do you think they're prepped? I know they did a wonderful job with the adult side of the vaccination. And how are they dealing with the stress so far? And do they need more training from us that we can actually support them in a different way?
Actually, they have been doing pretty good. Okay, like from across the offices, from the business side. Thank you for the support. As you've known, we have did a lot of adjustments with everything, with from seeing the patients, from bringing them in, and we are in constant discussion and constantly changing practices in order to get everybody to make sure that we are seeing people, we're offering the services, but of course protecting people who are working for us or who are working with us. So both are very important.
They don't get enough credit, like I just want to make sure that we are extremely thankful for our medical staff in our offices. They are kind of like, from the public standpoint, they're almost invisible, but they are the backbone of the system. And then we do want to thank them individually for what they have done so far.
Definitely.
Well, Dr. Liquido, thank you so much for joining us and giving us the update. So good luck with the process, and then we'll be talking to you soon anyway. Thanks.
Okay. Thank you.
Thank you.
Bye-bye. So, Sean, we have our next topic is, we've kind of started this conversation. It's kind of interesting with this pediatric population, because every time I say, well, kids should be vaccinated, they ask me if I have kids and I don't, and then, well, then I shouldn't be giving, like if you're not a clinician, you shouldn't be giving medical knowledge. If you're not parents, you shouldn't be telling people to get vaccinated. But the reality is, well, the science is there, and then it's clear, and we have to really protect this population. Now, speaking of population, our next topic is a little bit interesting in a couple different ways. We have done this before, so I'm actually getting some people joining some session that I'm running, but it's not on Microsoft Teams. I hope Anne is watching this. So I'm getting some updates from Microsoft Teams, but anyway. So we'll go back to the value-based. So Sean and I, we kind of did prep a couple different ways of making you understanding what the challenges that we have with the value-based contract. So now, why this is important is because this is where we spend our time these days. So to make this easier to understand from the public standpoint, and also if any of our employees are watching this, they would also understand better what we are dealing with. So we kind of choose this 100-patient challenge. So we made up this name, right, Sean? So
yes,
we didn't borrow this from, this was just us. So 100-patient challenge, we are going to demonstrate what actually real problem is in the value-based contracting. So, so let's look at this. Now, before we start, Sean, did you want to kind of like tell us like what the issue that we were trying to describe here? So, and I will
so
this Microsoft Teams because I'm getting messages. So, hold on. All right.
Yeah, so if you look at our visual here, we have our triple aim approach. And obviously, if you see it includes, we have better care, lower cost, and improved health. And, with the value-based contract, our main approach is to have the best care for our patients proportionally to what they need. Obviously, different patients are going to have different needs, but throughout our ACO, we want to provide the best care, the best health condition, improve health, and also keeping the cost as low as possible. So just some questions to think about on the side, for maybe outside viewers, kind of get the ball rolling is, what magnitude impact would each patient have on cost? We also have here, are there certain ways that we can mitigate the cost with our patients? And then also how impactful is preventative care? So trying to tie all these together they all kind of help compose our value-based contract as a whole. And we kind of wanted to use this example here to kind of dive in and kind of show people just how impactful each patient actually is on our holistic ACO organization.
So now we picked real examples from our real contracts, right? So
correct.
One of the things is that now you've been in this field for now 3 weeks, 4 weeks maybe. Mm-hmm. And as I'm actually going through some of these things for you, probably it was a lot of information that you are seeing. Now, there's this perception of population health management, and there's the actual need. And I see this as like as we are in these programs, I see this as a kind of like a big it's a big challenge for medical mm-hmm. practices, but also it is a huge misunderstanding from many medical offices and by public too. So now there is the quality of care, and there is a prediction of future with the quality of care that we are providing. So this is from the population management part of it. And what's being kind of ignored is the high facility expense and high pharmaceutical expense, like the medication.
Yeah.
So this is something that we are hoping that this could help people to understand. So let's start this together and then see what we have here. Now, the numbers we have here are real numbers. So I'm going to actually use my drawing stuff here. Okay. Now, this is the actual, we won't tell which insurance, but this is a real analysis of one of our contracts. So now this is, so Sean, what's this number? Is it number of?
Yeah, so our 1197 there is representing the patients that are covered by that total cost of the 48 million. So in order to provide care for those 11,957 patients, it is having an annual cost of $48 million right there.
Now, what's really interesting, it's going to be here is, we'll take this 11,957. Here's our 100 patient challenge where the name is coming from.
Yep.
This is high risk, high cost. 100 patients out of, let's call this 12,000. 100 patients out of 12,000. The total cost out of this 48 million is
14.5, which if you look at that, that's almost a third of the total cost of what it costs to take care of the entire population of the 12,000.
So now, because, as the newcomer to the United Medical, we get to torture you. So you didn't know this, right, before, like how bad this...
No, I had no idea how skewed it is. I mean, obviously, there's going to be variation within, but, having seen that only 100, people out of that 12,000 are making up almost a third of the total cost, it's kind of makes you take a step back, and realize the impact that each of those patients actually has. And then similarly on the other side, that, 11,000 and change are having such low costs that we're able to keep such a large group healthy and, at a lower risk for future cost.
So this is our biggest challenge. So let's just make sure that people understand this so that there are no mistakes. 100 patients out of 12,000, that's less than 1%, is responsible for 30% of the total cost. meaning our total cost for this group of people is 48 million, and 14.5 million is spent for 100 people. So that's kind of like that. This is a real number. Now from here, what we want people to understand is the average cost for the. So let's see. These drawings are everywhere. So the average cost of this 100 people, that's 145,000, right, Sean?
Correct. Yep. So with those 100 people in the high risk group, obviously, if you divide that 14.5 million by the 100, it's going to cost on average $145,000 to take care of each of those patients.
So this is how unfair this distribution is, or proportionateless. It's not proportionate. So it's kind of like there's a huge issue. Now, why we want to point this out? That's actually kind of important. So the main reason that we want to actually point this out is because we are trying to do population health management. So let's say, like again, my crazy analogy. So if we have 10 kids, so I just find out Sean has 5 siblings, or you're one of 5.
I'm the youngest of 5, correct.
And then I'm the third out of 4. So if someone has 10 kids, okay, 10, and then they're from different ages, different needs, and all that. So the parents are going to distribute their time equally. Well, that's not, that may be fair from dividing those time, but it's not from the need standpoint, it's not fair, right? The youngest may need more time than the oldest. I think the population health management is kind of focusing many of the providers into this, like divide your time equally and then just make sure that everyone gets equal amount of time from providers, which is not the case because 30% of the expense is coming from 1%. 30%, 1%. So that number is just totally crazy. Now, this one, I'm going to actually just share the screen. Sean, what we have here is now this 6,900. Okay, so you have 2020 and 2021 numbers. Just tell us what these numbers represents.
Yeah. So with your insurance plan, there's going to be the cost of a premium. So we kind of have a visual here to kind of help people understand. So with our examples, we have a guy named Jared here on the left. So his cost of the premium, he paid $6,900 in 2020, and then again $6,900 in 2021, having his 2-year cost of paying in $13,800. Now, if you look at Jared, we have some underlying conditions here. So it says, look, no underlying health conditions, exercises daily, doesn't smoke. So relatively, if you look, as he just circled his risk score there, he's going to be a relatively lower risk. He's healthy, he's taking care of himself, lower risk overall for his future cost of healthcare. Whereas on the right, we have Brian here, as you highlighted, we have a higher risk score. And what is that based off of? His underlying conditions down below. So maybe he has high blood pressure, maybe he smokes, has a higher BMI, overweight possibly, maybe he's on dialysis. So these types of underlying health conditions are going to obviously in the longer run lead to a more costly healthcare. But similarly, if you look, his cost of the premium, same as healthier Jared. So Brian paying in 2020, $6,900, 2021, $6,900. So the two of them are paying equal $13,800. Whereas if you look at the actual cost of the care, being that Jared was healthier, he didn't have to have any operations, as many scans, as many follow-up visits maybe. He only cost a total of $745 over that 2-year span. Whereas someone in Brian's condition who maybe has unhealthier lifestyle, more underlying conditions, if you look at his 2020 costs and 2021, the actual cost of his healthcare runs over $300,000. Looks like $321,000 for those 2 years. And if you just make a quick note on the bottom, we do have the average of the low risk, high risk group there. So it has an average of $3,837 for someone in the lower risk category, whereas someone who has a high risk, our 100 patient challenge, again, as we mentioned earlier, that 14.5 million divided by that 100, we're going to have an average cost of $145,000.
So now what we are demonstrating here is this is one of the insurance contracts that we have, and we are given like 12,000 people to manage. But then those 12,000 people, 1% of that 12,000 people are in charge of the cost of 30%. Now, why are we saying this is because I personally believe that we are actually not looking at the cost of the hospitals and the pharmaceuticals, so that we are not really focusing on those. Now, when we were getting ready for this session, I was just showing something to Sean, and I'm going to show it to our people. So now, because I also was saying earlier that Sean and I, we don't know each other. Like, it's just pretty much limited time that we have here. So sometimes when I present some of these things to him, like, I'm looking at his reaction and he thinks that I'm just crazy, and then I have to show him what I mean and then kind of give him the background of the problems and issues or my point. So when I saw this slide, this news actually from UPenn here, and we are not advertising them obviously, but I just want to make my point. Now, this is a hospital supposed to be, okay? So let's, this humongous facility. So now, okay, come back here. So now many people will think that we are jealous, but let me just show you what I mean. So this is the new campus of UPenn Penn Medicine. This is not the spaceship. It's not the space station. This is not Ritz-Carlton. This is a hospital. Okay, I think this is wrong. And look, this is on their website. Like, I'm not making this up. This cost a lot of money, right? So now here's one of the pictures that they have from inside. I thought we were trying to get care, we weren't trying, our plan wasn't to move into the hospital. We just needed to get what we need and get out of there. Hospitals are not safe for long-term stays anyway for the patients. Many people get infections and other stuff, and they shouldn't be staying there. But who's paying for this, right? Who's paying for this? Like who's going to get services from here? Our Medicare population and our Medicaid population together, 55%. Who's actually, how we are subsidizing these two programs is from our taxes. So 55% will get this type of service just because, like, how is this relevant to the patient's care anyway? Like, the cost of this, like, this is a lobby, like this is just some obnoxious, and Sean was making this comment earlier about this art. Yeah. Probably he was asking me how much that cost. I said probably 300,000. So who needs this? Like, why are we looking for this? Like, Sean, do you really need to get this type of hospital to get better from the like, if you have any sports injury, like, is that what you need, or you need?
So yeah, we could definitely look at that as being rather irrelevant. If you look at your list of priorities of what you're actually is most important during your visit, it's going to be your healthcare. It's going to be your interaction with the medical staff. I highly doubt people are going in and getting a warm, fuzzy feeling from the artwork that they saw in the lobby and then magically feeling better with their medical, conditions.
The cost of this building, this project, this is not a new hospital, by the way. They did have a hospital there. This is $1.5 billion.
Yep.
Like billion, that's a billion. Like, that's 1.5 billion. That is just insane. And this is why also healthcare in the hospital setting is more expensive. So that's one of the reasons that this is happening. This was the projected number. I don't know what they end up spending. They probably spend more, but that's just crazy. And no one needs that type of hospital. But what we are trying to say is that if now, actually, let's make sure that we are not being misunderstood. We are not saying that we won't want to do preventive medicine, this or that, but we are just saying that where we put the emphasis, we are maybe wasting too much resources to keep already healthy population healthier versus 30% of the expense is coming from 1% of the population. So that actually is what the point that we are trying to make. So now you're going to say, well, Kemal, you have contracts. We have 6 of them, 6 contracts with these types of contracts. So it doesn't stop us participating in these. And we are actually, we are very successful of saving for the insurance companies, even with the limitations with the facility and pharmaceutical part of it. So, but the takeaway from this one is just kind of like trying to kind of understand what it is that we are trying to achieve. We really need to reevaluate the system in place and then make sure that the resources are distributed properly, but also look into the hospital and the farm cost to see if that can be done at a cheaper level. That's kind of like what we are trying to say here. Now, Sean, anything that I missed?
I mean, just to recap on, what you touched on right there, kind of I had that visual in there with our upstream, downstream. And, part of that is just, you think of your preventative care where it's, if you take care, say, maybe lifestyle changes, maybe, so say like for an example, hypertension, say somebody, if you're having a lifestyle change, they're changing their diet, they're starting to exercise, regularly throughout the week. Down the road, that's going to pay off, both health-wise and actually, financially. Whereas, someone who maybe is not taking care of themselves as much down the road, certain conditions may begin to develop. Whereas someone who is taking this preventative approach, it will definitely pay off in the long run.
Sure, absolutely. Well, enough about boring hospital expense stuff. So, but we had a really good week this week. We, Brandywine Valley SPCA, I'm one of the advisory board members there. We had the groundbreaking for our best friends, our puppies, our dogs, our cats. So this is a only no-kill open admission shelter in PA and Delaware. So this makes a huge difference. And it's the only ICU, animal ICU that's going to be available. So we had the groundbreaking, I believe it was on Wednesday. Our Lieutenant Governor, our former First Lady, and most importantly, Tatiana Copeland, she actually is one of the generous animal lovers. So she was the main donor for this project, and we want to thank her for her willingness to do what she did. And this was really great to see because, and we are not trying to build anything close to UPenn Hospital. So it's not about luxury, it's about the need and the technology that they need. And this is something that the community needs because a lot of people, they're not able to get affordable help and affordable care for their animals. And this place is going to take care of that issue, hopefully. And we are in 3 different counties in Delaware. But this is the biggest one and the only ICU. So hopefully many people will be able to access and get help from them. So we do have our Bariatric Friday session coming up in 10 minutes. So Sean, anything you would like to say before we close?
I mean, definitely it was a great cause, with the SPCA, and definitely it's going to make a big impact on the community. It's definitely a great end-term goal that they're, reaching for and trying to make a difference here in the community. And, I think we had a really productive session today. And, I hope that, for those that see this, they're able to, take away at least 1 or 2 things from our session. Maybe they learned something new or kind of get a better understanding of some of the topics that we touched on.
Absolutely. Well, thank you so much. And well, have a nice weekend, everyone. Thank you for watching us. And we'll be back next week. And we'll be back actually in 10 minutes for Bariatric Friday. Thank you again. Bye-bye.